So as I mentioned previously, you want to use the DSM-5 criteria to guide your diagnostic interview. You can go through the different symptoms, the different attentional symptoms and different hyperactivity symptoms, and ask the patient. You can come up with all sorts of creative questions that might get at the specific symptoms on these lists. That's what a lot of the screening tools and other diagnostic interview tools are doing. They're giving you other questions to ask to elicit these symptoms. I think it's important to continue to stress that you must find how these symptoms impact functioning. There has to be some negative impact on social, academic, occupational functioning of some kind in order for the symptoms to qualify for the diagnosis of ADHD. Between the DSM-4 and DSM-5, there are only a couple of small changes with the diagnosis of ADHD. Most notably, the age of onset or age of detection of symptoms went from 7 in DSM-4 to by age 12 in DSM-5. The evidence of impairment had to be seen in at least 2 settings at this point with the DSM-5. The exclusion for autism was removed, so you can have both an autistic spectrum disorder as well as a diagnosis of ADHD. The number of symptoms required to meet a diagnosis in childhood is at least 6, either attentive or in hyperactivity symptoms. But now for adults, one is only required to have 5 symptoms to merit a diagnosis of ADHD. It's not uncommon for the hyperactivity symptoms to become less noticeable in adulthood and are often less noticeable in girls relative to boys as well. There's all sorts of speculation as to why that might be the case, but knowing the fact of that association is enough for our purposes now. You can give someone a diagnosis of ADHD inattentive, ADHD hyperactivity, or ADHD combined type. You can also specify if it's mild, moderate, or severe. Someone with mild ADHD would have only enough symptoms to merit the diagnosis and minimal dysfunction as a result of them. Someone with severe ADHD, obviously more symptoms, more impairing. As with almost all mental health diagnoses in the DSM-5, there are caveat diagnoses of specified and unspecified, whatever it is. So in this case, specified or unspecified ADHD. These diagnoses are used when there is a specific reason when the physician believes there to be an ADHD diagnosis, but patient may not meet full criteria for the disorder. And so if you were to specify the reason why they did not meet the specific criteria and your rationale why you still believe them to have ADHD, you would use the other specified ADHD diagnosis. If you chose not to specify, you would use unspecified ADHD as your diagnosis. As mentioned previously, there are a number of screening questionnaires or self-report measures that can be used to aid you in making your diagnosis of ADHD. I have here on screen the adult self-report scale for ADHD. It's a symptom checklist. You can give this to a patient. They can make their circles and then you can score it. Or you can just use it to guide your interview. There's a number of these out there. The DIVA is a special diagnostic interview for ADHD. The Vanderbilt is a very common rating scale that's given to parents and teachers or another informant to collect that collateral information in order to make a diagnosis. There's a whole bunch of these things out there. You can look at sensitivity and specificity measures of these things and be dismayed. I encourage you not to. But rather just to use the criteria and use them as tools to aid in your clinical diagnosis that you're attempting to make. When you're doing your history and physical, there's a number of things that you might look for. More often you might pick this up in children or in a primary care setting. There are things like changes in motor coordination, difficulty with fine motor activities like drawing or copying figures, reflex asymmetries, and perhaps some perceptual deficits. So like I said before, deficits in perception may then cause deficits in higher level cognitive functions. And so if you find poor auditory or visual discrimination, that may make it very difficult to attend to an auditory or visual stimuli. So look for those things as well when you're doing your history and physical exam. When patients have ADHD, it's often causing secondary problems, which may be demonstrated in emotional ability, aggression, defiance, or problems making relationships with people. And so people have poor social skills because they're not able to attend to whatever it is that the person in front of them is saying. And so they end up not having friends, and then that can cause emotional problems, and a child may act out in some way. So there's some physical or neurological soft signs that might suggest a diagnosis of ADHD, but there are also some psychiatric soft signs, as it were, that you can look for when you're assessing your patient. When you're assessing your patient, you want to perform a workup, as it were. So you want to rule out a number of things prior to giving a diagnosis of ADHD. So you want to obtain a thorough medical history, look for signs of a seizure disorder, perhaps. Absence seizures may look like ADHD, particularly in children, or any other medical problem may cause symptoms that impair concentration or attention. So make sure you've ruled out potential medical causes. Are there hearing or vision problems, or things of that sort? Also be looking for a family history of not just ADHD, but also family history of heart problems. If there's a personal or family history of cardiac abnormalities, hypertrophic obstructive cardiomyopathy or something like that, or a valve defect of some kind, it makes the prescription of stimulant medication much more dangerous. And so you would want to know about that in either family or personal history. So it's something you need to be assessing for when you're evaluating your patient. There are no specific labs to order to make a diagnosis of ADHD. My practice is to before prescribing any psychiatric medication, to obtain thyroid panel, CMP, and a CBC, just to screen for medical illnesses which might be masquerading as a mental health problem. It's particularly important to evaluate for anxiety, depressive conditions, or sleep disorders or substance use disorders prior to making a diagnosis of ADHD. You want to make sure you're treating substance use disorders first, and sleep disorders and anxiety and depressive disorders before you start treating ADHD. Because you may find that once you treat those other things, the person doesn't have any symptoms that suggest ADHD. People who have a chronic anxiety condition may look like they have ADHD as well, but once you treat the anxiety, the ADHD goes away, suggesting that it probably wasn't ADHD to begin with. So making sure you evaluate for these things and treat them before you give a diagnosis of ADHD. If you find that the history is suggestive of ADHD based off the patient's report, the collateral history from the family is suggestive but not conclusive, you can do something called a Connor's Continuous Performance Test. It's a neuropsychological test that you would refer the patient to go get. It's basically a computer test where it's testing their reaction times and how well they're attending to things. All it will tell you is whether or not there is an attentional impairment or not. It won't tell you what's causing it. So if you've removed all these other things from diagnostic consideration, and the person has a demonstrated attentional deficit on this test, it might be reasonable to give them the diagnosis of ADHD and treat them accordingly. To begin with, like I said, you want to treat substance use disorders first, then mood, then anxiety disorders, and if all those are resolved, then you can go ahead and treat ADHD if the diagnosis is still if the symptoms are present warranting the diagnosis. I will oftentimes, if both things appear to be present, say something like, unspecified anxiety disorder as a primary diagnosis, and I will treat that, and I will have rule out ADHD beneath that as a secondary diagnosis. Once the anxiety disorder is treated to remission, then I will say, okay, there's still a presence of attentional impairment, substantiating diagnosis. Then I'll, formalize the diagnosis of ADHD and then proceed accordingly. You can follow the American Academy of Child and Adolescent Psychiatry and follow their recommendations for monitoring physical exam, blood pressure, pulse, weight, height when you're prescribing stimulant medication. It's less important in adults to be monitoring weight and height. The patient will usually, obviously be fully grown, so height's not so important. And then weight, the patient's probably going to report to you if they're gaining or losing weight. Oftentimes people are glad to lose a few pounds. Monitoring heart rate and blood pressure, though, is important, particularly when prescribing stimulant medication, but also could have some changes when prescribing something like Strattera or Wellbutrin even. And if you're prescribing clonidine or any of the alpha agents, you might want to be looking for hypotension. So monitoring blood pressure is important when prescribing these medications. Obviously, once the person's stable on them, it becomes less concerning, but you want to be tracking it nonetheless. Once you've made your diagnosis and you've assessed the patient thoroughly and treated any other comorbid disorders first, you then begin treatment of ADHD. It's reasonable to go ahead and start the behavioral and psychosocial interventions for ADHD long before the anxiety or depressive condition is treated to remission, because those interventions are very benign and might in fact be helpful for the anxiety and depressive conditions themselves. So to begin with the behavioral interventions, you want to coach the patient in organization skills. You want to talk about list making pro and con lists, finding ways to set up reminders for the patient, using your phone, alarms, all those sorts of things. So helping the patient learn to organize. You yourself can do that as the physician if you have the time, or you can be referring them to talk to a counselor about these sorts of things. You want to encourage the patient to maintain a regular schedule. It's easier to remember to do things if you always do things that way. And so having the same schedule every day, or a weekly schedule, something of that sort, can decrease the frequency with which the patient may fail to remember to do something or misplace something, or have to rely too much on the impaired attentional processes of their brain to focus on a task to get it done. If some things are habitual or routine, it's easier to do. So maintaining regular schedules. Helping the patient plan ahead and minimizing distractions. Obviously, you don't want to do your taxes when the TV's on. If you have ADHD, probably not going to do them so well. So learning to minimize distractions. You want to help the patient make short, medium, and long-term goals. So you yourself can do that in the context of a therapy session, or you can coach the patient to engage in that sort of planning with a significant other or a friend or a mentor of some kind. So helping the patient have that forward vision, short, medium, and long-term goals, so they can organize their daily behavior with that schema. Sometimes with children, it can be very helpful to use a reward or a token economy. So hey, like positive behaviors get rewards to kind of increase the level of dopamine and nucleus accumbens. Say, hey, you successfully did this task, I therefore reward the task. That can increase the frequency with which the task gets completed. Using things like charts and checklists are often used for children in classroom settings to improve attention and focus. People can do that as adults themselves, and so you can coach the patient in those behavioral interventions as well. Looking out for things that may reinforce negative behaviors or cause further impairments in attention is also an important behavioral intervention. If you have a patient with ADHD who also happens to have been drinking or using drugs or having the TV on all the time, you want to let them know, hey, look, those things are going to impair your attention as well, and so we want to eliminate those things to try and improve your attention as much as possible. Interventions such as exercise and mindfulness do have some evidence to suggest that they improve people's attention and concentration and may be helpful in ADHD. If you look it up to date, they'll tell you that those interventions are considered unproven. I myself am in the practice of recommending that people engage in regular physical exercise, not just for their cardiovascular health, but there's plenty of lines of evidence that suggest it's good for mental health as well. And I see no reason not to assume that that is the case as well in ADHD, given some evidence leaning in that direction, albeit inconclusive at this time. Same with mindfulness. So mindfulness is a core aspect of cognitive behavior therapy. and a number of different other types of therapy. And so I encourage people to engage in a practice of mindfulness as well. The psychosocial interventions for ADHD begin with psychoeducation. You teach the patient what ADHD and what it is not, and give them some sort of an expectation of how things might progress in the future. Most of the people I tend to see tend to be very young, or in their late teens, early 20s, and so I'm often telling people to expect their brains to continue to develop until their mid-20s. Maybe the brain will finish developing a little bit later, and hey, look, those symptoms might resolve moving forward. So beginning with psychoeducation, explaining what it is, and a plan for how it might progress. Using cognitive behavior therapy as another psychosocial intervention to help the person modify their behavior and their ways of thinking about their own thoughts and their own ability to attend to a way that maximizes their functioning. The third and final type of intervention is the pharmacological interventions, either the stimulant medications or the non-stimulant medication. It's important to keep in mind that you're looking for a kind of the peak. Peak attention is going to be somewhere of moderate level of stimulation. Excessive stimulation is going to cause problems with attention. Too little stimulation will also cause inattentiveness. Stimulant medication comes in two main types: methylphenidate or amphetamines. Dextroamphetamine comes in a couple different flavors. The mixed amphetamine salts comes in a number of different flavors. And methylphenidate, as I've said, comes in a number of different formulations or flavors, as it were. The most commonly prescribed stimulant medications are going to be Concerta or extended release Adderall. Concerta and XR Adderall are both slow release type medications. They usually last between 8 and 12 hours, or at least that's the hope. Clinically, I found that usually getting somewhere between 6 to 8 hours of efficacy with either one of those. It's common practice to prescribe an extended release stimulant in the morning, followed by an immediate release booster dose sometime in the mid to late afternoon to see the patient through the working day or the school day, as it were. Different patients may or may not experience side effects with one rather than the other. There is some evidence to suggest that Adderall or the amphetamine compounds are more addictive than methylphenidate. And so my practice is to tend to prescribe methylphenidate or Concerta first. If the patient doesn't tolerate that or finds it ineffective, then I'll go to Adderall as sort of the last step. Starting with an extended release formulation in the morning is reasonable, and then kind of titrating it up in small increments, and then making the decision about whether or not to add a booster in the afternoon. A common example: a patient will come in, I've gone through the history and physical, made my diagnosis, I've tried the non-stimulant medications, found they were ineffective, and then go to stimulants. I'll prescribe 27 milligrams of Concerta, see how they do over a week or two, and then titrate that up over the course of the following weeks, oftentimes getting to a dose of 54 milligrams of Concerta, which is the average effective dose for an adult, but can go as high as 72. Some of the more unique formulations of stimulant medications, the patches, can be very useful when you have someone who is having problems with insomnia related to the medication, because you can just take off the patch and you're not getting the drug anymore, and so kind of turn it on and off, as it were. Some of the other special formulations of the stimulant medication, so Vyvanse or lisdexamfetamine, is unique in that it is a prodrug itself. It has to go through first pass metabolism in the liver to remove a lysine, which then makes the psychoactive compound in the blood, the dextroamphetamine. If I've had a patient who has found Concerta to be intolerable or ineffective, then I would go to Adderall. I often start people off at a dose of 15 or 20 milligrams of Adderall XR. If they're pretty small, I'll start at 15. If they're 150 pounds or more, I'll start at about 20 milligrams of XR Adderall, and then titrate up in increments of 5 milligrams every couple of days to a week or so. You can follow the specific recommendations from UpToDate with each one of these. I highly encourage you to reference UpToDate for the specific titration schedules for your own reference, to improve your memory of these things, because you're going to be looking at it every time you go to do it anyways. When you're prescribing these medications, if you have a patient who has a tic disorder or an anxiety disorder, you want to be aware that you may make those things worse by prescribing a stimulant medication. If somebody has a psychotic disorder, bipolar disorder, or something like that, obviously you might make things worse as well. So unless you're a psychiatrist, I would not be in the business of prescribing or treating ADHD in someone with a severe mental illness like bipolar disorder or schizophrenia. When you're counseling patients about using stimulant medication, you want to discuss the risks associated with it, some common physical side effects that people can experience. The big things, though, to be concerned about are, causing psychosis, blood pressure problems, impact on physical health, things like that, and addiction. In someone with a history of a substance use disorder, you want to be very cautious about prescribing an addictive medication. How do these medications work? Methylphenidate will block the norepinephrine transporter or the dopamine transporter on the presynaptic nerve terminal. That will block the transporter at an allosteric site, so it doesn't block where the dopamine goes in. It's blocking at a different site, and prevents the presynaptic neuron from taking back up the norepinephrine over the dopamine, as would normally happen in order for the neuron to kind of recycle and reuse the neurotransmitter, so that it doesn't have to be making it over and over again. The brain is very efficient in that it likes to recycle its neurotransmitters. And so by blocking that transporter, norepinephrine and dopamine remain in this synapse longer and will stimulate the postsynaptic nerve terminal with greater intensity. There is some evidence to suggest that the various isomers of methylphenidate have differing potencies or different pKa's at the receptors, and so you do have formulations of D versus L methylphenidate, and so you can try those with patients as well, if you get that far down the algorithm. Amphetamines worked very similar to the way in which methylphenidate will work. Amphetamines will not only block the norepinephrine and dopamine transporters as competitive inhibitors, so not at an allosteric site, but as a competitive inhibitor. So it's a pseudo substrate. It can actually be taken into the presynaptic nerve terminal. So since it's going to the same site as the dopamine in the reuptake pump, the amphetamine can actually be brought into the presynaptic nerve terminal, and then can actually make its way into the vesicle that stores the dopamine or the norepinephrine. The amphetamine's presence inside the presynaptic nerve terminal and also being moved into the synapse, or not the synapse, the vesicle, can change the concentration gradients of dopamine in the presynaptic nerve and in the synapse itself, and can actually reverse the direction of the dopamine transporter, so that you're actually getting more dopamine coming out of the dopamine transporter. So not just into the synapse, so not just the normal route of dopamine release with fusion of the vesicle with the nerve membrane dumping the neurotransmitter into the synapse, but an actual change in the direction of the transporter because the concentration gradient has been shifted. So it is believed that phenomenon accounts for the increase in addictive properties associated with amphetamine products. The non-stimulant medications are of three types. There is Strattera, which is a norepinephrine reuptake inhibitor. There is Wellbutrin or bupropion, which is a norepinephrine and dopamine reuptake inhibitor. And there are the alpha adrenergic agonists, including clonidine and guanfacine. Strattera, or atomoxetine, usually reaches its peak plasma level in 1 to 2 hours, lasts about a half-life of about 5 hours, so it can require twice-a-day dosing, which is somewhat inconvenient, but the stimulants obviously are similar in that respect. It can take longer to get the benefit of Strattera than the stimulant medication. That's true of all of these non-stimulant medications. I will often tell patients to whom I prescribe Strattera to expect to wait, 2 to 3 weeks before you notice much, maybe as long as the 4 to 6 weeks that we're typically telling people to observe for benefit from an SSRI or something like that. The mechanism of action of Strattera, we believe it to be dealing with increasing norepinephrine in the prefrontal cortex, similar to the way the stimulants work. It's a less powerful experience, though, for the patient, to be sure. Side effects from all these medications or Wellbutrin and Strattera, rather, are going to be fairly similar. So you're looking for things like changes in blood pressure, the typical nausea, vomiting, headache, that sort of thing. Any side effect that I might describe for an SSRI, I'm often going to describe, yes, you can experience those things with Strattera or Wellbutrin as well. Of note, there's a seizure risk associated with the use of Wellbutrin over 400 milligrams a day. Typically, you're prescribing it in 150 milligram increments, and so that's, well, if you get to 450, then there's an increased risk of seizures. The risk is still relatively low, but that is something you should tell the patient. Changes in mood or irritability associated with stimulants or Strattera are not uncommon. It's a little bit less common for that to happen with Wellbutrin, in my experience, but it's something to be observing for and to caution the patient about. The alpha agonists are unique in that they may cause hypotension and bradycardia. So that's very different from the stimulants or Wellbutrin or Strattera. And so they tend to be more effective for hyperactivity symptoms, as you might imagine, and are often prescribed in that fashion for children. And so it's not uncommon to have a primary stimulant medication for ADHD in a child and using the alpha agonist as an adjunct for the hyperactivity specifically. Dosing for these medications is, as you see over here on this list here, for adults, I'm typically starting at 40 milligrams of Strattera, given that a couple of weeks, and then going to 80. You can increase to 80 in as little as a week if you so desired. When I've used 10x in the past with adults, I'm often starting at 1 milligram a day. Sometimes I'll prescribe it in the morning if they can tolerate it. Oftentimes I'm prescribing it at night. Then kind of titrate up by 1 milligram each day up to the maximum of 4 if it is effective. The mechanism of action of Strattera, since it's a norepinephrine reuptake inhibitor, it's primarily functioning in the prefrontal cortex, we believe, increasing the levels of norepinephrine in the synapse, increasing the levels of attentiveness, because as we've discussed previously, the association with increased levels of dopamine and norepinephrine in the prefrontal cortex leads to decreased impulsivity, greater attentiveness. In the prefrontal cortex, when there is no alpha-2 adrenergic receptor stimulation by either norepinephrine or guanfacine, there is a higher level of cyclic AMP in the cell right here, which then causes the opening of potassium channels, which then decreases the ability of this cell to fire. And as we've discussed previously, when the neurons of the prefrontal cortex are not firing, it's going to be more difficulty to attend to stimuli and to inhibit extraneous distractions and stimuli and impulsive behavior and things of that sort. When these neurons are stimulated by the alpha-2 agonist, either norepinephrine or guanfacine, in the prefrontal cortex, you are going to have closing of those potassium channels because cyclic AMP is inhibited, and that will increase the rate of firing of the prefrontal cortex neuron that it's targeting, and hopefully the efficacy of the neural network that it's involved in. It's important to keep in mind that this impact of an alpha agonist in the prefrontal cortex is not particularly related to the impact of these medications on blood pressure. And so do keep in mind that the use of these medications does have an impact on blood pressure, and to make sure that you are slow in titrating these medications up and slow in titrating them off if they are to be discontinued. You want to watch out for rebound hypertension if you are discontinuing either clonidine or guanfacine, and want to make sure that you are slowly tapering by no more than 0.1 milligrams for clonidine or 1 milligram every 3 to 7 days for guanfacine. So do a slow taper down if you're discontinuing this medication and had reached a previously high dose. The mechanism of action for the blood pressure effects is different from the impact in the prefrontal cortex and how we think it's working for ADHD. Thank you for watching this lecture. Here's a list of the references that I have used to put this material together. If you received this video from me directly, you will have also have received 2 different slide decks. One that has more notes in it, basically, and the other being just the ones that are shown in this video. Please do give feedback. Send me an email. I'm happy to answer any questions or concerns you might have, and I appreciate you participating and taking the time to learn something about ADHD with me.